My topic actually allotted is type 2 diabetes and obesity in adolescents. However, it's difficult to cover both of them in 15 minutes, so I have largely kind of stuck to type 2 diabetes, and we will look very briefly, we will look at obesity as well. It's moving. No? Can someone help me with moving the slides, please? Yes. So this is the outline for today's talk. We will look at prevalence of type 2 diabetes in adolescents. What are the risk factors for you to develop type 2 diabetes? We will look at obesity also in brief. We will look at how to handle a child or an adolescent who's come to you with type 2 diabetes and what are the therapeutic options we have. So if you remember the classification of diabetes many decades ago, juvenile diabetes was equivalent to type 1 diabetes, and adult onset diabetes was always called as type 2 diabetes. And we have really come far from that scenario where we are seeing more and more patients with frank type 2 diabetes. To such an extent that type 2 diabetes is now being recognized as a pediatric disease, whereas earlier always type 2 diabetes was considered as an adult disease. Even though overall numbers are it's still on the rarer side. However, any occurrence of type 2 diabetes in young is extremely concerning, and we will see why that is so. One of the reasons is that it has a very aggressive clinical course. This leads to risk of them having debilitating complications by young adulthood because the acceleration is much faster of beta cell failure. And also we have evidence to say that there is a higher all-cause mortality in young patients with type 2 diabetes and adolescents and children with type 2 diabetes. So when we look at the definition, it's very similar to what you have in adults. The cutoff values are the same. So I will not spend time on it. But this is Indian data from across the country which looked at the prevalence of pre-diabetes and diabetes. And you can see that in this graph, you can see that the diabetes prevalence is around 8.4%, which is quite high. And the pre-diabetes was around 12.8%. So you can see that we are dealing with a significant number of adolescents. This is between 10 to 19 years of age. So these are adolescent age group. So we are dealing with a significantly large number of type 2 diabetes in the young Indian population. So risk factors, I'm sure all of you are aware of, but we'll just briefly look at them. The primary factor is genetics. Of course, if you're genetically determined or have a predisposition to develop, then your lifestyle factors matter a lot and you will end up getting diabetes like ma'am just mentioned in the discussion previously. Of course, there is socioeconomic status, because if you belong to the lower socioeconomic status, then the kind of food that you can afford and probably predisposes you or worsens your lifestyle issues, which will worsen your risk for developing diabetes. We're all familiar with Barker's hypothesis and the developmental origin of adult onset diseases. However, now it's becoming developmental origin of pediatric onset diseases, because in utero environment is very important for beta cell programming and the risk of future diabetes. So here, history of gestational diabetes during the child's conception is a very important risk factor which will increase the chances of child developing diabetes in the future. And of course, there is endocrine disrupting chemicals for which we do not have much data. So when we look at other risk factors, one of the other issues is puberty. So when the child goes through phase of puberty, that's when there is a huge increase in the insulin resistance. In fact, puberty is associated with 30% reduction in insulin sensitivity. And if you remember the graph that I showed you earlier, across the age groups, the highest incidence was actually between 14 to 16 years, which is around the time of puberty. So a majority of the adolescent type 2 diabetes appears in and around puberty, which basically puberty is another factor which accelerates or triggers off this event. Now, obesity, of course, I left it out as one of the risk factors because I wanted to discuss it in the end. And this is the elephant in the room, right? Obesity, reduced physical activity, and poor diet are essentially the root cause or the lifestyle changes which contribute to development of diabetes. So many of us may have genetic predisposition to develop diabetes, but how can we correct that? by adopting appropriate methodologies to prevent onset of obesity. So obesity is really what we should be discussing when we see young children with diabetes. And today we are actually celebrating the World Obesity Day on March 4th. And this year's theme is actually Let's Talk About Obesity. And that is something that we have to remember to do, because often when we deal with young children, like ma'am also said, we are always worried about one aspect, the child, and the parents are worried about another aspect. So they may not come to you for obesity, but when you see a child or an adolescent who is frankly obese, it is important for us to put it on the table and have a discussion about it. So we had Tejal and Chitra doing some excellent work with language matters, wherein we got feedback from the patients who said that, they don't always appreciate the way we, kind of push our ideas down them. So I think maybe the way we went about it was not correct, but it doesn't mean that we have to stop doing it. We have to change our style of functioning, but it is really, really important for us to address the issue of obesity, because that truly is the epidemic that we are facing today. And if we don't address it, we're going to have a huge problem 10, 20 years down the line in our hands. So once a child is coming to you with diabetes, how do we proceed? What are the things that we should do? We have to remember not just look at the glucose alone, but also to look at, does the child have any other comorbidities and or complications of diabetes? So what are the comorbidities that are generally associated and we should screen for? We should always screen for NAFLD. You can start by doing AST-ALT at diagnosis and then annually. And if there is any doubt, you do further investigations or refer to a gastroenterologist. Another aspect which is often overlooked in children is OSA, associated with obesity. So always ask them questions which may give you clues to presence of OSA, like daytime somnolence, too much of snoring at night, habitual snoring, and also having apneic or hypopneic spells in between their sleep. And if any of these symptoms are present, they don't necessarily mean OSA, so it's important for you to screen the child for OSA. Of course, we had one entire session with regards to PCOS, which ma'am has discussed essentially. Another thing that we should not forget is the psychosocial factors as well, because there is a lot of diabetes distress and body shaming associated with obesity and diabetes, which is something that we should also remember to address when we are handling them. Now, coming to the complications of diabetes, what are the ones that we should search for? So every time a child comes, to our clinic and is newly diagnosed to have diabetes, and when we tell the parents, okay, this does not look like type 1 diabetes and we can manage this with medicines, they're actually very, very happy. They're like, thank God my child does not have insulin-dependent diabetes. But that is not true. Because if you look at this slide, you can see this is a slide which compares the incidence of complications between type 1 and type 2 diabetes, and you can see that type 2 diabetes has such worse prognosis when compared to type 1 diabetes. In fact, if a young child is diagnosed with diabetes, you should pray that it is type 1 and not type 2, because in the long run, the type 1 diabetes children fare better. So this is why we as clinicians who are handling these young children should also be extremely wary of this, because they have much higher acceleration of beta cell failure, which leads to a higher degree of oral hypoglycemic agent failure. Treatment failure is much higher in young type 2 diabetes when compared to adult onset type 2 diabetes. And as you can see here, risk of complications which occur in young adulthood is going to be much, much higher. So it is important for us to be aware of this. And just because they are young, do not forget to screen them for complications. Just like you do in adult onset diabetes, screen every patient with young onset type 2 diabetes also for all complications. So for nephropathy, you will do your creatinine, check the blood pressure at every visit, and if the blood pressure is high, of course, you do go ahead and further evaluate, and also institute lifestyle measurements and, if required, pharmacotherapy. Urine albumin creatinine ratio and creatinine should be done at diagnosis and annually, and of course refer to nephrology if necessary. Again, neuropathy, just like in adults, a thorough foot examination, just clinical examination essential, which can be done at diagnosis and annually. A dilated fundoscopy again should be done at diagnosis and annually. The cardiovascular risk factor testing again is important in patients with type 2 diabetes and in the adolescent period as well. We have to do the lipid profile at diagnosis and annually. And of course, I think looking at the complication rate, it is important that we are aggressive in managing them. But remember, when they are young, particularly in young women in whom we start ACE inhibitors, ARB, statins, etc., it's important for us to counsel them regarding the safety of these drugs in pregnancy. And so they should always have a planned pregnancy if they are requiring these drugs, at which time we will have to alter their medication. So lastly, coming to the therapy and what we can do for them. Of course, all of them should have lifestyle intervention, but if you have frank diabetes, you can always start metformin along with lifestyle intervention. The starting dose of metformin is very similar to adults, 500 to 1000 milligram, and you can up titrate it to 2 grams per day. Now, once, along with metformin, if the child is having, of course, frank hyperglycemics, if the child is presenting with DK or HHS, of course, HHS can present in pediatric type 2 diabetes. So if the child has any of those complications, of course, you will manage it like an acute hyperglycemia and treat with intravenous insulin, later transition to subcutaneous insulin. However, if the child has very high HbA1c or is having symptoms of hyperglycemia like polyuria, polydipsia, nocturia, and weight loss, then this is a situation where you would start insulin along with metformin in order to get better control of the hyperglycemia. And if the hyperglycemia targets are not met in a child who does not have any symptoms suggestive of hyperglycemia or osmotic symptoms, but with metformin, if you are not reaching the target, and if the child is obese, GLP-1 receptor agonist is a good second drug to add because it works very well. It will also improve their weight, which is also a stressful factor for them. Once, if you started the patient on insulin and you have met the glycemic targets, then along with lifestyle interventions, particularly if their weight is coming down, you can actually de-escalate, try to reduce the insulin, and maybe you can even taper and stop it and manage the child on metformin alone. Of course, if the glycemic targets are not met, then you have to intensify the insulin regimen. So you will go from basal only to, basal plus or maybe even basal bolus regimens. So that is in a nutshell how you could handle children with type 2 diabetes or adolescents with type 2 diabetes. So in summary, we looked at the risk factors, and the predominant risk, we cannot modify the genetic risk factor that we have, but it's good to know it so that we know what our baseline risk is, that is family history of type 2 diabetes in one or both parents. But obesity and lifestyle modification is something that we should stress upon in each and every visit, because that will truly make a difference. And of course, comorbidity is something that we should look for when a child is for the first time diagnosed with diabetes. And more important than that is to understand that they have a high rate of complications when compared to adult onset diabetes, and it is extremely important for us to screen them for this. Thank you very much.